I have a few items to go over before we begin the program. Each of our panelists will take 5 to 10 minutes to briefly discuss how population health management is affecting their practice and the community in general. After the panelists finish their introduction, the floor will be open for Q&A session. There are 2 ways to ask your questions. You can write them down on the cards provided at your seat and give them to a TCMS staff member that are wandering around, or you can step up to the microphone right over there. And I ask that you keep your comments to a minimum and state your questions quickly so that everyone has an opportunity to have their questions answered. As you've noticed, tonight's program is being video recorded, so please refrain from talking during the program. And when at the microphone to ask a question, please speak clearly into the mic so that your question can be recorded. Tonight's program is covering population health and what it means to the practicing physician. Here in yellow it says, insert your comments about population health. That's my comments. If I had some comments, I'd be over there on the panel, so I won't bore you with my comments about population health, and let's go to our experts. Our panelists tonight are Dr. William Turney, Bill, an internist and medical informaticist who serves as the chair of the Department of Population Health at the Dell Medical School. And prior to coming to the medical school, he was president and CEO of Regenstrief Institute, the country's oldest research institution dedicated to improving health systems. Next, we have Dr. Kevin Spencer, who specializes in family medicine at his practice, Premier Family Physicians. In addition, he's the president of the Southwest Provider ACO, a physician-owned organization focused on delivering high-quality care, lowering costs, and improving the overall patient experience. The ACO encompasses 21 provider groups, 273 primary care physicians, and over 31,000 Central Texas patients, of whom I'm glad to include myself as one. Following Dr. Spencer is Dr. Randall Schultz, who's with Texas Orthopedics, Sports and Rehabilitation Associates. He specializes in and is fellowship trained in orthopedic sports medicine. Dr. Schultz is the chair of Texas Orthopedics Bundled Payments for Care Improvement Initiative Committee, an initiative specifically for lower extremity total joint replacements. And more importantly, he's a Rice alumnus. Woot! And last but not least is Dr. Anas Dagestani. He is the CEO of Austin Regional Clinic, serves as the medical director of Population Health and Clinical Quality at ARC, is the chairman of ARC Clinical Quality Committee, president of the ARC Executive Board, chief of ARC's Internal Medicine Department, and he's the leader of the ARC Medical Home, a patient-centered model of care through an organized system of communication and a proactive approach to care. So again, we're going to let each of the panelists speak for a brief 5 or 10 minutes, and then after they're finished, then we'll open up the floor to questions. So let's start with Dr. Tierney. Bill?
Thank you. I'm going to stand up because I'm short to begin with, and I can't see half of your faces. Before I get started, I wanted to recognize we have 5 medical students here from the inaugural class of the Dell Medical School, so don't hurt me too badly. They still think pretty highly of me. About 18 months ago, I was called by the dean of the School of Medicine here and asked to consider being the chair of the Department of Population Health. And my first thought was, what the hell is that? Because I don't know that I ever used that term in my career. So I looked it up, and it turned out prior to about 10 years ago, there were fewer than 10 articles a year published that had the term population health in either the abstract or the title of the article. This year, there'll be more than 1,000. So I also started looking up, so where are there other departments of population health? There were about 5 at the time, and they were all kind of epidemiology research units. And so I started thinking about, if you're going to develop a population health thing at a medical school, what is it? What should it be? And so I started thinking about and started looking at different definitions of population health. And I started asking people, and every time I asked somebody, I had a different definition of both population and health. And in fact, I heard people telling me, what's this population health stuff? I treat patients, not populations. What do I care about population health? Today, how many of you saw Texas Medicine Today? It's in my mailbox this morning. There's an article in there about 5 suggestions of how to respond to MACRA. Number 2 was, look how your patients are performing on quality measures. It's population health. The population is the patients for whom you have responsibility for their care. They've signed on as you as their primary care doctor, their specialist, or whatever. You have some responsibility for their care. If you're running a clinic, then you have responsibility for the people who receive care in your clinic. If you are an HMO, Kaiser, Geising, or something like that, you know who your people are because they're signed up to get care for you. If you're an insurance company, you know who your population is. If you're a health system, it's a little bit harder because people come and go. If you're a public health system, it's people living in a geographic area. And if you're a city, county government, it's the people that live in your catchment area. And health can be anywhere from making sure people are getting high quality care and hitting the quality targets all the way to preventing diseases that otherwise you shouldn't have to treat them for. And I started realizing at the time that I was called to consider this, I had just finished a 5-year stint as the chief of medicine at the 4th largest safety net health system in the country. If you took Breckenridge and added community care and doubled or tripled it in size, that's what we ran. And we tried to do a really good job, and there's evidence we did a really good job of dealing with the people who came in our front door, and we didn't care a thing about it, people who didn't come through our front door. And yet, researchers at my prior institute, the Reagan Street Institute, had done a really neat randomized controlled trial of patients with pre-diabetes, where they took half of the patients and they just gave them, they just had monitored their usual care in the same health system that I eventually was the chief of medicine in. This study was about 12 years ago. And the other group got usual care plus a free pass to the YMCA. And the YMCA implemented parts of the diabetes prevention program. These people had half the incident cases of type 2 diabetes compared to the usual care group. So lifelong treatment for a debilitating condition that I must admit a third of the patients that I cared for in primary care, I never controlled. And treating some for almost 30 years, I watched their legs go numb, their eyes go blind, their kidneys fall out, they get heart attacks and strokes, and it was really frustrating. Maybe you can treat it better than I can. I really struggled in inner-city health system with a lot of barriers to care getting patients treated. So if we can prevent it, then why not prevent it? If you care about the population, why not prevent it? Turns out if it were easy to prevent, it would be prevented. The interventions to do that are not in your black bag or your toolkit. They're in the community. Because we all know what it takes to be healthy, right? You got to eat better, you got to exercise. You cannot smoke, not drink excess, and get a lot of sleep. At least that's what my wife tells me. Continuously. And yet, if that were easy to do, it would be done and we wouldn't be having this conversation. It's not easy to do, especially in parts of the community that don't have access to parks and don't have street lights and sidewalks and things like that. Don't have fresh fruit and vegetables in grocery stores in their neighborhoods. So there are structural things that actually affect 2 or 3 times as many health outcomes as the health care that we all deliver to. So I took on probably the last step in my career. I wanted to get out of my comfort zone, which is working in a health system, and what can you do outside the health system? And at the interface between the health system and the community. So we built a department that kind of lives in that interface. So we've got clinical divisions within my department. We've got a division of primary care and value-based health, a division of family and community medicine, and a division of occupational medicine. And arguably, if they do their jobs, population health should get better. If the occupational health program is going to create programs with occupational health, workers' compensation, and workers' comp care, and primary care for workers and their families. You do that for enough big employers, just start getting a big chunk of the population involved. But you can't do it without data. You can't make something better if you're not measuring it. And we're all now drowning in data, but starving for information. I mean, you're all using electronic medical record systems, which we studied for 30 years and probably half responsible for the stuff you're stuck with these days. And the data are often not where you need them at the time that you need them. And mostly we have data from health care systems, not health systems. So the nearest place to get to exercise and get community, the nearest place where people can buy fresh fruits and vegetables and things like that, the barriers to care that are outside the things that we normally care for are things that are intervenable by the health system. And for a primary care physician, I care about those things. There's a good example of that. There was a physician, and I'm blocking what city he was in, that was frustrated that he kept prescribing exercise for his patients and they kept not doing it. I know this never happened to you, but it happened to him a lot. And so he finally he said, look, he sent a message, an email to all his patients. He said, I'm going to be down at this park on Saturday morning at 8 o'clock with my family. I'm going for a walk. Join me. And people showed up. And he did it the next week, and people showed up. And soon there were people who weren't his patients who were showing up. And he had 1,000 people walking with him on the weekend. And arguably, he moved the needle in people's exercise. And so he began writing about that. It metastasized to other cities, another thing called Walk with a Doc. that's actually being done in many cities all over the country. We're going to be initiating here. It's something simple to do that somebody who cares about prevention in their patients ought to be doing for themselves anyway, and doing it with your patients is one way of delivering care if the care is to prevent the things that we otherwise have difficulty treating. So data is going to be in my department too. So all of the activities that the medical school does surrounding data, health information and data analytics sciences is going to be generated through my department, because it's all about the data. We work in an information business, and the quality, efficiency, and outcomes of care depend entirely on getting your hands on the right data in front of the right people at the right time. Finally, other than we're going to have a research mission that's going to focus both on primary care, health system care, and community-based interventions and the interface between those things. And finally, global health. Now that makes no sense. If the medical school is supposed to be helping make Austin and Travis County a model healthy community, what the hell are we talking about global health about? Two reasons for that. One is that these guys expect it. That half of the medical students are coming in who've had experiences internationally, and initially when they asked who wanted to be part of an international health or global health interest group, 40 of the 50 students signed up. So they expect to get it, and if you want to get the best students, you have to offer an experience. But in reality, healthcare in a developing world context is population health. They don't invest in dialysis machines and radiation therapy machines, sorry Ryan, or ICUs. They invest in clean water and vaccinations and antenatal care, and antibiotics for TB and malaria and things like that, and diarrheal illnesses, oral rehydration solutions. Those are the things that make a difference in that context. And when the students come back, with my experience having worked in Kenya for 12 years when I was at Indiana University, the students come back with a better appreciation for what they're getting for their investment in health, and how that money might be better spent, and looking at a population perspective. So that's what my department's going to be looking like, both dealing with both primary care and with the community upstream from the need for care, hoping that an interface between the two will move the needle towards reducing the things that are causing debilitation. The goal is that we're all going to get sick and die, right? The goal is to compress that morbidity into the last few weeks and months of your life so you're healthy as heck and fall off a cliff at the end, hopefully at 112 years old. But it's that compression of morbidity that we're after, keeping people as healthy and as active and as functional as they can, and doing it both within healthcare and upstream from healthcare. Thanks.
So again, I'm Kevin Spencer. I'm going to sit, if that's okay. I hope you guys can all see and hear me. If not, I'll stand if you need me to. I'm going to, that was well stated in a great big picture. I'm going to, if I may, kind of descend us down to the question was, what is population health to me? And so I'm going to kind of talk a little bit about my week and just to give you an idea. So again, I'm the president of a 20-physician, 42 provider practice in Southwest Austin, and then the president and CEO of a ACO here in town, a physician-led ACO. And our mission really was to bring, honestly, contracts to doctors that they can't get by themselves, and to execute on those contracts to help all of us do well, and for our patients and for ourselves, ultimately. And so what we've seen is a movement, as we've all seen, towards what they term value-based care. CMS is really setting the tone there. Many of you know about MACRA and MIPS, and they're really going to press this down, and the payers are following. So I'm running a business, a couple businesses, where 85 to 90% of my business is a fee-for-service business, and 10 to 15% of my business is a value-based business. And so, as you might imagine, that can be pretty challenging. And so population health means to me that I contract with my patients to be their doctor, to give them the highest value care at the best cost that I can, that makes sense for them, and that we execute, and then that we improve physician satisfaction while we do that, the quadruple aim, so to speak. And so that's kind of what it means definitionally. Fundamentally, we hire nurses, care coordinators, utilization review, data analysts, and we get all the data from the insurance company that shows how are we doing across this population of patients. Again, it's not all of our patients, it's only select patients. and then we go and try to execute at giving those patients a better experience. And so that's what that looks like. It looks like who's in the hospital, how long are they there, what are they there for. It looks like patients that have increased their ER utilization, that we're getting that information to the physician. It looks like meeting all of our quality measures that every payer asks us to meet, and many times it's different quality measures for different payers. And so again, looking at that, it's doing the analysis of how much of that information do I bother my physicians with. You know, if they're all meeting their hemoglobin A1C measure, should I even be talking to them about that? Because they already, again, I can't waste one more brain cell of their time because there's something else, another button in the EHR they've got to press, another meeting they need to go to, another consideration they have. So how do we both synthesize all of this information, this data that we're getting, and get it down to actionable data that actually matters, first for the patient, second for the organization, and third to execute on the contract. And so that's really what that really looks like in our world. So it looks like nursing teams, care coordinators. It looks like keeping the patient base attributed to us. So a lot of these contracts that we sign are based on an attribution model. So you have to see the patient at least once a year or every 2 years. So it's running reports looking at, well, who's not come in? They're on my books. They may be spending money. It looks like a lot of outreach to patients. And then the very deepest level, so I would say before we get the privilege of involving the community to really affect the high spenders and the people who go to the hospital, what we focused on is what we do control in our organization. So there is a lot of quality that we control. There's a lot of access. We've looked at, should we hire more physicians? Is it time to do that? Can we stay open later? Why are they going to the ER for unnecessary care at the wrong cost of care? We've looked at a little bit of the way we work up musculoskeletal injuries to make sure we're doing that efficiently and effectively, and we're teeing that up for the surgeon at the right time so that they're getting an effective procedure. So those are the types of things that we do. We kind of basically make a playbook. We look at all of our data that the insurance company gives us over the last 2 or 3 years, and we decide where are our opportunities. The hospital is always your biggest opportunity, so we've made attempts to really partner with hospitals to see, can we affect the cost of care there? Can we be aligned in certain areas and affect things like ambulatory care sensitive conditions that you don't really want in your ER? Can we affect length of stay? Can we affect doing an OBS versus an inpatient admission? Are there smart strategies that help you? Can we really affect and be a win-win together on your readmission rate? And so those are the kind of conversations that we have, honestly, across all of what I just explained with varying limits of success. I'm proud to say that on all of our contracts that we have improved the cost of care 100% of the time on every contract. On our Blue Cross contract, we're actually able to distribute significant dollars to our physicians as a result of that in our first year. And so, but it is a steep learning curve. There's a lot to learn. A lot of this, honestly, is I would like to claim it all as an opportunity. I really see being involved in value-based care as an equal opportunity in primary care, but also a defensive posture. This is how they're going to pay us, and building the infrastructure, beginning to understand it, being able to execute on it, knowing how it works, how much staff do I need, what is it, how much cost do I have to appropriate to this, where are the real opportunities. Before 50% of my population is paid this way instead of 10 or 15, we really need to understand that if that's where the market really goes. Always with the understanding that one stroke of the pen in Congress, it may go a different way. Our belief, the more we listen, learn, and listen to both DC and here in Austin, is we don't think that's going to happen. We feel like with the passage of MACRA and MIPS that we really, that this is here and will continue to be there. My belief is it'll take probably a full decade to get fully implemented, but I think we've started down the path, and to lead physicians, I think in this era, it's responsible to be prepared for it and to build those relationships. So that's kind of at a more granular nuts and bolts level what population health looks like to me.
Is that working? Right here? Okay, hi, I'm Randall Schultz. I'm an orthopedic surgeon, an oddball up here with Texas Orthopedics. And the reason I was asked to come is because we're participants in a bundled payment program with Medicare. I won't go into too much of the mechanics of that, but it's a BPCI model too, which is a value-based program that we have agreed to participate in with CMS and Medicare. And it involves total joint replacements. And as you all know, value-based care is essentially improving quality and reducing cost. And the way Medicare does it with us is it's based on a 92-day episode of care involving major joint replacement of the lower extremity. And we are based against our reference costs from, I believe, 2013. And we are allowed to share in the savings of what how we do compared to how we did in the past. We also have to prove that we have improved the quality, and the reason we decided to do this is because we felt like we needed to understand our costs, we needed to understand our outcomes, and we're a fairly large group of over 30 predominantly orthopedic surgeons, and we knew that this was going to be the future with private payers, and this was a good place for us to start and learn. And boy, what a learning experience it has been. Total joint replacement is a hugely expensive payout for Medicare. It's in the billions on a yearly basis. And they saw this as a relatively easy area to sort of define what the costs were, understand those, and see what could be done in these value-based programs. We also wanted to be what's called the initiator of our program. You can also go through a hospital-based bundle program, which is going to be mandated in this market starting in January through what's called CJR. But we wanted to be the initiator of our program to understand our costs, be able to control the entire care episode. So we elected to participate in that BPCI program. We're the only physician group in town currently doing that, and it's now closed to others. But what we realize is that there is a tremendous amount of waste in the system. And through a combination of different strategies, we've been able to cut the cost dramatically from what we did just a few years ago and improve the quality at the same time. I think probably most significantly is through a process we call optimization. We now have very good data on understanding what are the variables that are modifiable that predict poor outcome in joint replacement. We've also been able to somewhat narrow our network of clinical care providers. Those who understand what we're doing, the program we're involved, are very, very helpful in keeping everybody on the same page and their incentives all aligned. Through care management, post-acute savings has been the biggest chunk of what we've been able to save in the program. We have generally tried to align ourselves with different skilled nursing facilities and rehab hospitals, and when they're necessary, we use them. But the majority of those post-acute stays were unnecessary, and in fact, patients who went through post-acute had inpatient stays actually had worse outcomes than those that were able to go directly home. So we do a lot of things now. We have home health visits that take place prior to surgery to go over the patient's home, look at areas where they might trip and fall, where things are dirty. All that's been very helpful. Another aspect is patient activation. Making the patients understand that they're not just passive participants in this whole process. A lot of their outcome is how actively they're involved in their own health care. And this is honestly a true story. Some of the hospital bundles have already come online, and they now report our data publicly on how we're doing, and they call it a value report card. And one of the physicians from one of the hospital-based bundles was upset that one of our surgeons' data looked better than his and said, well, that's not fair. That guy's doing people that, BMIs are under 40 and they don't smoke and their blood pressure's controlled. And we turned around and said, exactly. So we're not just orthopedic surgeons anymore. We're actually actively involved in people's health care. And there are maybe some people that fall out that we don't deem are candidates for joint replacement anymore, but there are at least twice as many, if not more, who we've actually had a meaningful effect on their health in general. People that we've finally gotten to be able to quit smoking rather, who get their hemoglobin A1C under control for the first time in their lives, are able to lose weight, get on a regular exercise program. So it's something we're very proud of, we're excited about. We've been thus far very successful. I think it is the future. Medicare loves this idea of budget neutrality. They want to know what they're going to spend on these procedures, and they're getting a pretty good handle on this, and I'm glad that we're participating in it. So thank y'all for having me here tonight.
I'm going to stand just to not let Dr. Turney be the only one that stood up today. So, Anas Dagestani, I'm an internist, been with Austin Regional Clinic for 12 years. So I think if we start on a high level, I think most of us would agree that all of us got into medicine, whether we're in a hospital, we're a physician, or we're specialty, nursing, to just do a good job. At the same time, we have businesses to run that we have to make sure that the business is viable. I think the same, a great system that basically created the level of research and created the level where everybody, talks about the United States maybe having lower numbers of quality, but everybody that I meet from anywhere wants to come here when they get, any health issue. It's the same system that's created a fragmentation for us. So our challenge is how to survive the transition, basically. Because what it is at the end of the day, I think what we heard, we're hearing loud and clear from Medicare is they're on a mission. So it's not an issue of do we have a choice, it's an issue of how it will happen and when it will happen. We're also hearing it from the employers in town. They're also pushing for cost, but we also hear it from our patients every day. I can tell you my own, in my own family, my wife wouldn't let me do anything toward the end of the year until we meet our deductibles. So say, no, you're not having a dental procedure this year. Did you have your shared saving and all of that? So we're all feeling it basically every day. Austin is going to be special because of the strong economy of Austin, basically, that is going to make us live in this schizophrenic model where we're speaking about population health, meeting quality, reducing the cost, but we're all living in a fee-for-service model, and our payment depending on a fee-for-service model, whereas you can argue that it's the different incentive. It's about volume, how efficient your practice can be. So now we have to see volume be efficient, but at the same time, we're doing like everybody else, hiring a team and basically be responsible. So I think those are the high-level factors for us. So in the case of Austin Regional Clinic, we were approached in 2011 by the state of Texas ERS to experiment with, what now we call a value-based model, which means we're still in a fee-for-service world, but we agree on a quality measures, and if we meet the quality measures by the end of the year, and the total cost of care for the population that we're responsible for is lower than our trend or lower than the trend of the market, then we have a chance of sharing that, whether with the health plan or with the employer. And during the last 5 years, basically, that program have grew to about 200,000 patients now under that type of program with 11 different contracts with multiple payers, including Medicare. So we've learned a lot. We haven't figured out all of the details. We're still struggling like everybody else because we're still in a transition mode. But what we've learned so far is, one, you have to know where you are. If you don't know where you are, it's hard to plan. And you have to know the quality information. So that means, we all doctor, we hate technology, but now we have to actually coexist with technology and then maybe embrace it and maybe use it, basically. So we have to know where we are. So we spend a lot of time and resources investing into our own data warehouse to get the claims from the insurance, to know about everything that is happening outside the system. Even though we're a multi-specialty group, about 40 to 50% of the activities on our patient actually do happen outside the system. So that's one. Two, looking for partners in the community. So we're talking to the hospital system, we're talking to the home health agencies, we're talking to hospice, we're trying to improve connectivities between the two systems. We're trying to establish, common goals. We're talking to the specialty groups. Three is some of the things that we've heard from Dr. Spencer. So we're investing as well with case managers. Everybody has case managers. Hospital have one, insurers have one. Why not? We'll have ours. So now we have case managers. We do find that patients actually tend to listen to the RNs after a while more than they listen to the doctors. They just bond with them. They understand them. They can speak their language more than we do as a physician. We had to work with our partners and physicians to make sure that they understand that the change is coming. It's not a choice. It's a matter of if and how. or a matter of when and how, not a matter of if. And we've invested in also population health type of project where we're sharing with our physician how we're doing on cancer screening, how we're doing on disease management, how we're doing on prevention, how we're doing on utilization. And this year we're drilling down to the way where actually our compensation, part of it is going to be dependent on those measures. It's no longer 100% fee for service. So it's been a journey. I don't think we've seen even the beginning of the journey. I think it's very exciting to have everybody in town here to see both hospital system and a lot of the specialty groups and primary care, because we each have to find out in the transition the low-hanging fruit for our own individual situation. So in a primary care group, we've heard from Dr. Spencer, we're making sure we're attacking the waste in the system and duplication and errors as patient transition care from one site to another. We're trying to make sure we're finding a virtual network. We don't have an error network, but we're finding a virtual network of like-minded, specialty group and physician in hospitals. We're also starting to collect our data and get comfortable with displaying our data on an internal level. I can walk in an internal medicine department meeting now, which I would have had to wear a bulletproof vest 2 years ago and say, here's how we're doing on cancer screening, here's the name of everybody in the group. And initially there was a lot of resistance, but we're starting to see a lot of buy-ins, basically. So to me, population level is population health is actually what we always wanted to be, but it seems like the system have threw every obstacle in our way as physician to do that, which is do good care, be rewarded for it, and good results and financially. And everything we've done, they've been obstacle. You're rewarded for the wrong thing, you're not rewarded for connectivity, and now we're living this transition to figure out how we do what we were supposed to do to begin with. Okay, thank you.
We'll now open the floor to questions. If you have a written question, please hand it to a TCMS member. If you prefer, please line up at the mic. I'll take the opportunity for the first question. These systems that you discuss, they seem like you need to have an organization or a group. I'll just throw it out, and I'll give each guys a chance to answer the question. As this changes, does this mean the end of the ones and twos, the primary care doctors, the specialists that are going to be out there just opening up a shingle and practicing, or a couple of doctors coming together and practicing in small groups? It seems like what you talk about, the way insurance companies are going to reward good behavior and better outcomes, that the only way to survive in that kind of environment would be to be an employed physician, whether it's by other physicians in a multi-specialty or a single specialty group, or by a hospital system or an insurance company. Is this, as we transition, are we going to see the end of the small ones and two doctors? I'll start this way and go that way. Honest, what do you think?
You have to start with me, huh?
Yeah, I'm going backwards, sorry.
So I don't know. I think it's going to be challenging. Time will tell. There was a recent medical economic articles that did some projection that basically said, based on what MACRA, more than population health, is the payment model, basically that is going to be challenged for onesie and twosie practice, because what you've heard from all of us is the amount of investment into infrastructure that is needed. Having said that, I think all of us are trying to find solution, to connect with the right system, to invest in relationships. So we've heard from Dr. Spencer, that's a solution for primary care physician if they want to remain independent but connect to a system. California is a perfect example of that. We're still far away from that, but California, up until this day, with a lot of the organized system, there is still a lot of small practices, but they managed to stay together, find a common goal, and work with the groups around them or with the right healthcare system and remain independent. So I think there's definitely a challenge. I don't know that I'm ready to say it's the end of primary care. One of our physicians, they're probably well known to a lot of the physicians here, Dr. Marcus, Howard Marcus, he predicted the end of internal medicine about 10 years ago. He's actually starting to change his mind because, one, he doesn't practice that much anymore, but two, because he's seeing a lot of the things that are coming down macro is actually, in a way, if the incentives follow. Right now we have the rules and the punishment, but not the incentives. So it's a weird situation where the punishment precedes the incentives, that actually you need a functional primary care network to do that, basically.
Randy, do you think that the ones and twos orthopedic surgeons are going to survive?
We certainly don't see them very often anymore. It's funny, that's the first question I asked Kevin when we sat down here tonight. But our group certainly continues to grow. I think it's very, very hard for smaller groups to really have the specialization, the administrative staff they need to keep up with the emerging technology, these value-based payment systems, dealing with payers and complex payment systems. So generally in the surgical subspecialty, we're seeing either large groups of physician-run that are forming, or going with hospital employment or in the multi-specialty practice.
Kevin, you agree?
Well, I agree with what Anas was saying. I think the infrastructure and the ability to do business with who your customers are, which is the government, the employers, and the payers, is that they really are requiring increasingly for us to be able to report on ourselves and have data analytics systems that it's very difficult. I think the other option, which is part of what our organization is trying to provide, is the ability to join a umbrella organization that can provide that for you. So I think short of that, I don't see it unless you're going to do concierge care. That's my personal opinion. If any place can do it, it's Texas. If you look across the country, Texas is still the state with the largest number of independent physicians as this mass consolidation in the marketplace takes place. So we're fighters and we hang in there longer than most, but I really, in primary care, especially where they're asking us to do the bulk of the management of the overall total cost of care of a patient, while we only provide the primary care piece, I really, between the relationships, the data, and the ability to execute to find your high utilizers and help them get more valuable care and save money, I don't quite see the path for a onesie twosie to be able to do that. Again, joining an umbrella organization where you can keep a lot of your culture potentially, and you're willing to play by many of the same rules as your larger partners, I see that as in a lot of markets being successful. It'd be easier if we were all on one EHR, but we've been able to tackle that reasonably well so far.
Bill, what do you think?
Yeah, I guess the advantage of being old is you can see things change over time, and this started a long time before macro and value-based care. I mean, when I first started 30-some years ago, it was mostly small practices, and then as health systems started, hospitals grew into health systems and bought up practices and built these large physician networks. As payers have wanted to negotiate prices with large networks, it's been driving the individual provider out of practice long before all this started, except in rural areas. You know, there just isn't an option in rural areas. And so it is these umbrella service organizations that allow them to continue, and they're going to have to continue because that and the technology allow people to care for people over a distance. But it's not we can't expect patients to go hundreds of miles to get care. They're going to have to be small practices out there delivering the care that's really, and I think you're right. Texas is a good example of that. It has the largest number of rural counties in the country, and some with a single physician. So that guy's not joining a network, and he's not going away either. So there'll be some of that, but I think in the larger cities, there'll be some recalcitrant remaining, but I think mostly it's going to be a larger system.
So while you have the mic there, Bill, is there a country that the U.S. can look to model our goal of population health? What 2 or 3 things might that country be doing that we could model in 12 to 24 months?
I don't think so. I don't think so because we're starting from a very different position. We're not starting from scratch. We're starting from a very individualistic model that's already approaching 20% of our GDP on healthcare. And I don't think we can go back and completely redesign it from scratch. I think we're really creating something new here. And it is this transition that's difficult. I think most people can see how it might work if we have decent, reliable, easy to measure quality measures. You can see how this might work, but how does it work in the transition where most of your patients are fee-for-service and some are value-based? You have two standards of care? I mean, I actually sat, as we were becoming one of the pioneer ACOs where I came from, and I sat in a meeting of department chairs where the people were talking about having this is how we're going to care for people in our ACO, and this is how we're going to care for people not in our ACO. And I finally said, will you listen to yourself? You're talking about two standards of care. I said, there's nothing good down that road. The transition period is really what's going to be difficult, and that's unique to us. And so I think the solution is going to be unique to us. And I wouldn't try to follow another model because it's wrong. I think we have to come up with a unique model. And we are because of the things that you guys are doing that are creative, they're responsive, and you're learning. You've described the learning health system. I mean, I think that's what it's going to take, and that doesn't exist anywhere else on the planet.
Randall, I'll address this one to you. And by the way, if other panelists have a comment about any of these questions, some of these are addressed to specific physicians, but they're just toss-up. If you have a comment to add, please just feel to chime in. But Randall, for this question, can we care for subpopulations, bundles, for example, without addressing an entire geographic population? Said another way, bundles versus capitation or both. What's your interpretation and answer to that question?
That was my first thought when I was introduced to value-based care is, well, this is just capitation. Well, it's the financial side of it to some degree is measured against a reference cost, but quality is still a part of that equation. Now, we're in the infancy of these programs, and right now, a little bit of the way we measure quality is really more a measure of cost in terms of we look at readmissions, repeat surgeries. As we better define how to record outcomes and we come through with more unified platforms for measuring outcomes, I do think we'll be able to make this a more truly value-based system rather than one that's purely just trying to cut costs at this point in time. But the two are obviously very closely related, but I think that's the primary difference between a capitated program and what we're doing now.
Anas, how do you make hospitals play fair with you? They make more on the fee-for-service than lose out due to readmissions.
Well, I think, like I said before, I think the hospital system themselves, they have to see the value into this. I think the way value-based purchasing and the quality and the STAR measures, the hospital is starting to get affected by the same. So I think we're finding increasingly that we do have some aligned incentive, or historically you're absolutely right. Even in the previous model, people talk a lot about readmission penalty. A lot of the time, you still can do okay with readmission penalty, my understanding. So I think we're seeing more and more interest on the hospital side, and the reason that they're seeing, if they have the right strategic leadership, they're seeing that the payment model is going to be changing, and if you don't, move with the market, then the market is going to move. And I think we're lucky to be in a town where both hospital systems seems to be paying attention to those information.
Kevin, how can we catalyze the conversion of EMRs from billing engines to population health engines? Are there good examples existing?
It's a good question. I think we struggle with that now, and again, we're running two different businesses. So we've hired certified coders. We've even used some of our mid-level providers and physicians to put in population health codes, because when those codes go to the payer, then the quality measures automatically come off without us having to do a later data project where we're capturing that. And so, we're really going to need to look to our technology partners to be able to query that data out of our EHR and report it more automatically. Even now, we have to hire people to add supplemental data that we send into the payer. So for instance, a blood pressure reading doesn't automatically go to the payer, so we have to query that, send that in to prove that we met the blood pressure measure. Some of the lab data goes, some of it doesn't. So those are the challenges today, and I think we're continually looking for a technology solution to that and not a human resource solution to that. So where I see the market now is not there, but evolving. So we're watching that and looking for tools to do that on our behalf that we can scale.
Honest, you have something to add there?
Yeah, and I think what we're seeing even is that the platforms are closed. So it's actually even a challenge to get two platforms to talk to each other where, for example, we're in Epic. Epic doesn't integrate well with a lot of the other system. There's a lot of proprietary. So it's almost, again, it's the systems are closed. What we're struggling with is trying to make sure, because obviously all of our physicians are in the same boat. They're hearing about population health, they're hearing about the changing model system, but your salary and what you do at the end of the day has to do with fee for service. So what we're trying to do is, as much as we can, is get the information that they actually need to act on. So if there's anything that a nurse can do, then we're not getting that burden on the physician. If it's something that the front desk needs to do, then we're not actually involving the physician. If it's something that on a system level, we can do, then we're doing that. So we're trying very hard to be very cognizant of physician burnout as well, and to trying to make sure everybody's working at the top of the license. And I think that's the other thing that we haven't talked about as well, that we're trying to get comfortable with the team concept of care, which is really anti-physician. And I think you've probably heard, anti-physician in our mind. We trained always to be the captain of the ship. I'm responsible for the patient. Don't trust the system. Don't trust anything else. You verify again and again. And now we're telling our physician, well, you have to trust that this division is going to reach out to the patient on your behalf. You're going to have to trust the nurse who's calling the patient to do a medication reconciliation, that they're going to do a good job. So I think that's been a journey for us as well, to work as a team concept and to do what Kevin was talking about, which is basically not everything is on the shoulder of the physician, basically.
Thank you. Randall, I'll address this question to you. I think you alluded to it a little bit earlier ago. It seems like if we get rewarded for better outcomes, the easiest way to do that is to select healthier patients to start with. Are there viable ideas how to incorporate patient populations that are unhealthy? I mean, you alluded to the idea of BMIs over 40 and that kind of thing. So what's your take on that question?
Yeah, I mean, the argument against these programs is, well, you're going to cherry pick and just do the healthy patients. Well, no, we're going to make the patients healthy before they have this elective procedure. And to me, that's the definition of population health, and that an orthopedic surgeon can have an impact on that, I don't think is.
How do you do that? You make sure that they see a PCP before you touch them?
So we create protocols for, we do use a group of hospitalists that do our, what we call our optimization clinic. And we actually had to train them to some degree on some of these medical variables that are very pertinent to orthopedic surgery and joint replacement. And what we found is when we used to use the primary care doctors, who are great and they know the patient better than anybody else, but they don't know specifically what the hemoglobin needs to be for a hip replacement, what the hemoglobin A1C, what the data shows there, how to do the MRSA screening that we need to have to know which for appropriate antibiotic selection. So we do send them to the group of hospitalists. That hospitalist then knows the patient, and then when they're in the hospital, if any medical issue arises, it's going to be the hospitalist that's there to help take care of them. So that's the process we use now. We have created protocols. It's amazing that even things such as the psychiatric disorders can have a major impact on cost and quality in a joint replacement. So we've learned to even begin to screen for things like that. We've branched out and networked with other groups so that we can get appropriate care and treatment for these patients before they have their surgery, rather than deal with the problems afterwards.
Bill, the question is, I believe 50 to 60% of Medicare dollars are spent in the last 6 months of life. With this being such a large percentage of costs, how should this be addressed from a population health level?
There's been, you may have seen it about 10 years ago, maybe 8 years ago, there was a study that looked at Medicare expenditures per Medicare recipient by county in the United States. There was a threefold difference in the amount, adjusting for severity of illness, et cetera, a threefold difference in what was spent. And interestingly, the better outcomes were in these counties that had the lower costs. And so there's a lot of unnecessary variability there, and I think that's where CMS is hoping to find the savings, is by focusing on the things that are necessary, make sure that people get those things. then you get better outcomes at lower cost. And so that's where the whole notion of the triple aim came from. This kind of landmark study was about 8 or 10 years ago. So I think that yeah, we're still going to have this compression of morbidity at the end, but we can do that in a cost-effective way by making sure that patients don't get what they don't want. I can tell you the stories of my patients, my parents in the last 6 months of life getting all sorts of inappropriate stuff that we didn't want them getting, but we couldn't babysit them living in Florida. And they got a lot of unnecessary things that didn't help them at all, and in one case actually was fatal. So I just think that by focusing on value and doing it throughout the lifespan, we'll reduce the variation, and that's where we'll find a lot of cost savings. And that 6 months may go down to 3 months, may go down to 2 months. I mean, it can decrease, again, that compression of morbidity at the end.
I just wanted to touch on the aspect of the question he asked Randall and the comment Dr. Tierney made earlier about how would you take care of someone in your ACO and take care of someone else differently. And I think it's an important thing to discuss and address is in these attribution models, while Randall can appropriately, and for an elective procedure, I would argue that's probably potentially a good outcome when that patient doesn't have a PE or a post-op infection that we've saved them from and they just hurt a little bit more to walk a little bit longer. That's a completely different clinical scenario than what Anasa and I do, where we take care of patients and they have all of that, and many of them have very bad problems and they're very expensive. So you really have to guard against in the mentality of physicians gaming the system as this model evolves. I can look today at my 5 or 6 most expensive patients, and it's not really hard to frustrate them and get them to go see another doctor, if that's the game we all wanted to play. So I would say as physicians, we have to lead in this, and the conversation there is really with the payer. As they understand how expensive these people are, and we look at catastrophic cases and we look at the ability to impact care, we have to really think about that if we're going to hire a staff that literally may have one RN calling that patient every 3rd day, that's the level of care. Someone going to their house to see if they're going to trip and fall and see how dirty it is and see that they're not eating meals and see that their wound will never get better because their nutrition's poor. It's extremely expensive. Yet, if we impact that case, it's both our opportunity, because that's the person spending all the money. So if you want to incent us to share in the savings, you've got to really play fair. And they put too much of the burden on us to code those people appropriately. So now you're looking at a movement across the country with HCC coding and physicians trying to game the system on making everyone look very sick by coding them and so we've just got to come to a meeting in the middle of what's the right answer here, and let's create a level playing field that's not so hard for you to measure and not so hard for us to measure. But those are the conversations that we're beginning to have. We're not there yet, but I just throw that out there to say that does go on, no doubt about it. Not in our organization, not in Anasa's organization, but just something to think about. Is that's not the answer, is to game it, because in the end you always lose if you're not there for the patient.
Well, yeah, Anas, want to add to that?
I think this is a great opportunity for the medical school to help the community, because I think I don't know if any of you are familiar with the Gunderson model. It's basically they've done a lot of research on spending, and in their system when they started, about 50% of the death happened in the hospital. People basically went to the hospital, and actually they tried to engage and do it through the physician, and it didn't work. Then they tried to do it through nursing, and it didn't work. And then finally they went in a community campaign, went to churches, went to events, and used coaches actually, and it dropped from 50% to 20% within 2 to 3 years. I think this is a great opportunity in the future to do more of a public awareness campaign. Because I think if we engage the patient early enough and the family, then that will help, with the spend. And obviously, again, it's the misaligned incentives. If you have a situation like a bundle or even capitation, then some of that noise will fade away over time.
Well, you have the mic there, Anas. The question to you: why does Austin's strong economy make the transition to value go slower? You had mentioned that the Austin's economy was strong.
Yeah, so in the commercial business, we've heard about the challenge of being held responsible or accountable to the quality and the cost of a population that might have not chose you, it's assigned, or is not. So we're talking about the physician here, we're talking about the hospital, we talked about the health plan, we're talking about the employer. We didn't talk about the patient once. So the expectation in this community still is that I want to see whoever I want, anytime I want, and I want to get any test I want. We hear it from our patient all the time. I want an MRI of the back. Well, you don't need it. Well, does my insurance pay for it? Yes, well, I want it. So we hear that. So I think the reason is going to move slowly, multiple reasons. One, we've actually historically, Austin have lower spend. So we've been lucky to have a good, cohesive system, and Austin historically have had lower spend. Two, none of the large employers in this town are interested in doing benefit design, where they actually make it easier for us to control the cost, because it's just a competitive market that, I'm sure IBM and Apple don't want to have restriction and let their patient go to Microsoft or vice versa. So that's the strong economy makes it less likely for an employer to create benefit designs and things that helps us as specialists in primary care to take care of the patient.
And Kevin, you mentioned Blue Cross earlier and the success you've had with them. Do different insurance companies have different standards for value-based care for the exact same population?
The short answer is yes. I mean, I would say there's been on the commercial side and the non-Medicare Advantage side, there's been a fairly consistent model in Texas where you're paid fee for service with a care coordination fee up front, and then on the back end you split the savings with the insurance company. So in that large scale design, now as you look at the individual data within that, the way they attribute patients to you and whether they're in your contract or not, and whether they stay on your contract, which quality measures they want to measure, how often they want to measure them, what data they'll share with you. So for instance, some payers will give you all the claims data and we can see everything that they cost, and some won't, and there's no consistency. But so in a broad scale there is, but granularly, that's the part that's our job, right, as we run the umbrella organization, is we have to know every contract, know what we have to report on, know when it's due, know why this payer wants this and a different one wants that. That's a lot of administrative time and overhead that we spend. So if we could get it to streamline. In fact, we tend to build most of our protocols to the lowest common denominator. So if one has 12 quality measures and one has 9, we just kind of do 12 quality measures. So the physicians and the physician assistants and the nurses in the organization just gets used to doing that on every patient, not to think as much. But it requires that level of finesse because they're not all exactly the same.
I'll address this to the academic. Bill, would universal health care, single payer, make the goals of population health easier to achieve?
Yes.
That seems
I
like
mean, there's a trade-off between having individual freedoms and economies of scale. I mean, I just think that there's such a huge amount of overhead goes into all the things that Kevin just mentioned, all that stuff. If that were all one set of expected outcomes, et cetera, and it could be administered by different companies. It would just be one ultimate set of standards. Then it'd be a lot easier for everybody. But as it is now, the chaos that we're in, everybody suffers from it. So the inefficiencies add up.
All right. Randall, what's the likelihood, do you think, that physicians will get any reduction in liability when we give up control to insurance companies, mid-levels, and things like that? Are you seeing any changes in your liability from bundled payments and improving outcomes for lower costs? Do you think that's coming? Where's our TMLT rep here? Just get a little break here. All right.
No, not specifically. I do know our quality is improving, so in that regard, we should see less actions. But there is an element of trying to get people to act at the top of their license, as you mentioned, Anas mentioned before, and so we are, probably deferring some tasks to mid-levels and such. But I think, we haven't perceived it as being a typically hostile environment for us at this point.
Yeah, in Texas, particularly with our tort reforms that we've had, I think we're pretty successful in keeping liability rates down.
I've got to mention that there's always this worry about medical malpractice. And I've seen the worst physicians, the patients that give them a kidney. Okay, it has to do with how you communicate with your patients. It has almost, in fact, there was a very nicely done study in Utah and Colorado that I published when I was editor of the journal Medical Care that found there was no correlation between malpractice and awards. There's no correlation at all. And so the study that looked at that has shown is that it's all about the relationship with your patient. And if as long as you can have a team-based care that the patient sees as beneficial to them, and they have a relationship with that practice with the team, with the physician at the head of the team, then I don't see any increase in malpractice. And Kevin just mentioned he thinks they're actually showing, and what Randall said, the care is actually better. So I don't worry, and you've got Good Malpractice Act. It's out there, so you don't have to worry about this stuff. Practice good medicine, communicate with your patients, and don't worry about it.
The converse of this is, in the old fee-for-service model, if I replaced your hip, you dislocated it day 3, I reduced it, I would get another procedural fee for that. Then you go and fall and break the hip, or I have to revise it. Then I get paid 3 times as much for the guy who does a good hip, and you're done, and it's over with. So, no, I think these programs are incentivizing better care.
And so when we talk about these care teams, Anas and Kevin specifically, how effective has it been educating the patient that they're getting good care when they get less face-to-face time with the physician?
Yeah, that has been a challenge. I think it's been a 3 to 4 year journey. Now, again, we're still in a fee-for-service, so they have not, most of our patients have had the same time with the physicians to a degree. But actually, when we started the program, we got a lot of pushback from our patients about why too many people know about what's going on with me. I want to, privacy is a concern. Why are you sending me a letter saying I'm due for the screening test? Who authorized you to do that? So we did have to deal with some of these, but these are all anecdotals. I think to the point about team, once actually you explain to the patient that this is a team, the physician is still leading the team, and even you have the system as an umbrella, then actually a lot of people are receptive to that. We've also noticed some generation differences in some of our more senior patients. They just don't like the change. They're used to the physician. And some of our younger generation is actually they expect this. They demand this. They get upset when they hear that I send them to a specialist and I don't have the results back. They don't understand it. If they can connect everything on their iPhone and Samsung, why can't a group figure out all of the results? So it hasn't been a big deal yet. In one of the clinics that we did, which is the high-risk clinic, which we took the 0.5 sickest or most complex patient of the whole system, and we actually changed their primary care physician and put them in the clinic wrapped around with behavioral health, an hour appointment, and a 24 hours access. It was a huge fight to get that started. Patients didn't like it, physicians didn't like it, nobody liked it. And it's still a challenge. Now the patients that have finally got into that clinic, they love it. And they spend more time with their nurse and with the behavioral health than they do with the physician. They do like it, but it's been tough to ramp up that clinic.
Kevin, what's your experience been?
Yeah, I mean, I want to be careful here in a room full of physicians when I say this, but I want to just share what the market is bringing is, we work in a model with one physician for 1 or 2 mid-level providers kind of caring for that patient population, exactly in a care team model where the physician is the captain. And I have patients across every socioeconomic status, but certainly a fair number at the upper level of the socioeconomic status, including many physicians. And I would say that surprisingly, if this is done well and they know you're involved and they know you're reviewing the data, the predominant reception has been that that's expected and that's normal, and they just want it done with excellence. It's no longer is that being done, which allows our physicians to care for a population of people far greater than they need to. And that certainly may not fit every specialty and may not fit every situation, but in primary care, where we have a shortage of primary care, I think we are not going to be able to care for the population, and certainly a growing population like Austin, if we don't have some model like that. And so that's been our experiences from a being seen in the office perspective. The converse to that is we've had mixed results on our chronic care management platform that we've rolled out, where we're actually having health coaches and nurses reach out to our Medicare population to provide care. And when it works, they love it, and they bond with this person very quickly, and they understand that they've got an advocate within our organization following them across the board. And when it doesn't work, it's met with confusion over who is this person? Do they really work for you? Where's my privacy? What are they doing? I don't find value in that. And so we're having to coach our patients on, and I have this conversation 5 times a week. I'm your physician. I need you to trust me. You may or may not find the value yet, but when I know that person's called you, seen every specialist note when they changed a medicine, changed it on your med list, synced your med list, looked at your hospital discharge summary, got you a transition to care visit with me within 48 hours to make sure we don't have a readmission. There's a ton of value, and sometimes that month or that quarter you're well and there's not much going on. Awesome. And I find a lot of value, and increasingly I'm gonna press you to be in these programs because I can't care for you in the way I want to if I don't have help, because I'm being asked to care for you, and I want to care for you when you're not in my office, not just when you're here. That's what population health is. And this is the team of people that does that allows me to scale my care for you. And so I'm having to educate my patients, and that message is most powerful when communicated by me, their physician who they've had a many-year relationship with, and it's met with limited success when it comes straight from the RN for the people that rubs wrong. And it's interesting, as part of our Pop Health platform, we've looked at 5 different demographics that, believe it or not, the consumer data can feed into our Pop Health pop stratification platform. And so based on a lot of demographic, zip code analysis, gender, socioeconomic status, and consumer data, we're able to predict what kind of teaching these patients actually receive well. So you have a group that's direction followers. So when I now see that pop up, we pretty much know when that nurse reaches out to them, they're going to go with it. They're awesome. They're going to find value in it. They like it. It comes from me. And then some of the other categories find less value. So we're having to learn to speak to the patient in the way they understand it and create the value that they see in this system. It's all great if Anas and I want to run organizations that are going to do A to Z stuff for the patient. Well, the patient still has to be part of the solution. They have to understand it. They have to want to be in it. And it can't be just our show. And so we're having to figure that out. So all that to say, the question of what's it like in team care, I would say in the office care where they know I'm also there watching everything, home run, gone well. Able to care for more people and do a better job. Reaching out telephonically and via information system platforms, mixed review.
Am I reading this question correctly? I would like to speak about solo practices. There's an audience member that wants to come up and say a comment. So while she's coming up to the microphone, I'll address this. What's the impact of telemedicine on population health? Is that a fair way to interpret that? Okay. So you guys, while she's, you guys have answered the telemedicine and its role in population health?
So I think telemedicine is the next virtual urgent care. I think, 1, it's good access. I think 2, it's a way to make sure that you can reach your patients, and they can reach you when they need you. I think 3, if we don't do it, somebody else is going to do it on our behalf. And I think 4, if you're going to be responsible to a population, to Kevin's point, is you're responsible for them outside the office. And telemedicine, if you're not part of that platform or you don't vet that vendor, then you're having a company that's running from Hawaii, for example, with retired physicians that don't understand the community, don't understand the access, don't understand where they need to go, and don't have a connected to the system. So I think it's going to happen. It's the next wave of virtual urgent care. The question is, can we do it here in town, or is it going to be something that's going to be offered? I know right now that when we look at our health plan, we're surprised actually that a lot of them are already offering that for their members. I don't think I've heard from one of the health plans that they've had 100,000 visits on telemedicine platform here in the state of Texas in 2015. So it's flying under the radar right now, but I think it's very important. We're actually working closely with Premier and with ADC and trying to see is there anything that we can do and offer.
A couple of things. One is that it's similar to what Kevin said. It's a lot about expectation setting. If your patients see that as another way of contacting you, whether it's telemedicine with you or your team or whatever, it's just an extension of you. It allows you to have more arms and legs and ears and eyes and hands. Then it's seen as a very positive thing. The second thing is just think about it. If somebody's really sick or really disabled because they're chronically ill, multiple chronic diseases, et cetera, they've got social conditions at home, forcing them to come to your office is really pretty dumb, okay? And it's just as dumb for you to go to them because you can't see very many. What do you have to charge them to be able to do just all house visits would be prohibitively expensive. This is a night in between where you can manage a lot of things from a distance effectively. I mean, think, I listen to my patient's chest and heart every time. I've almost never heard anything worth listening to. It's the hand on the shoulder that's more beneficial than the stethoscope on the chest. So being able to manage that from a distance is really key, especially for psychiatry. Because there are certain patients who won't come to a psychiatrist's office because they're sitting in the shrink's office. And so the telepsychiatry is actually one of the more broad uses of this, and it's a very effective use of this, because it's based on the number of touches. And the more ways you can touch somebody, regardless how, it's better care. So I think we're just on the infancy of something that's going to be it's going to be as disruptive and positively disruptive what we're doing as things like X-ray and stethoscopes and stuff like that. It's really going to be a game changer because it'll allow us to extend our ability to care for patients to where they live without having to physically go there. But we have to maintain the right kind of touching too.
I'd like to thank all of our panelists for coming. And as the last question, since we have Bill Tierney here, and Austin's very special in that we've invited and funded a medical school, and we have a Department of Population Health. I'll pose the question that Bill posed to me, to all of you. Take your turn here. How can the medical school help with population health? Alice, we'll just go this way and go all the way around. One thing that you think that they can do to help us.
So I think we're still all trying to understand that because this is a different take on a medical school. There's not a lot of medical schools in the United States. When you think of a typical medical school as a tertiary center, it's academic and it's high-end services and it's a lot of research and publication. What we're hearing from the medical school that they really have taken a different approach. So I think they're going to help us still with academic approach. They're going to help us with train physicians in this transition. We all feel it's a transition. I bet you 10 years from now, this physician trains in the new model. They think that we're coming from the dinosaur ages, basically. So I think train physician and look for opportunity where we can work together. Historically, medical schools have done a lot of work also on public health and working, with a safety net as well, and that's something that is really good for the community. Overall, Texas is not leading the nation in that, so that will be a good opportunity.
Randall, what do you think?
I think quite simply, interconnectivity and data sharing. I think University of Texas has the resources and the talent to maybe one day put us in a system where we can share data quickly, effectively, understand our outcomes, and from that we can learn a great deal. More research and studies can be done. What the medicine and practice, the University of Texas Medical School is different than most in that they're relying largely on the community physicians for training, and I think having to be able to tap into that data that's already out there in our communities by having some sort of universal platform will be enormously important to us.
Yeah, and I think similar to that is as we look at population health, as they have that department and they're studying best methods from across the country and other markets that are more mature in population health than we are, to bring those lessons learned to us and to also study population health across different health spectrums. Traditionally, in a lot of the studies that I've seen, it's been on the vulnerable populations, which I think is critical, and I think that can help our practices incorporate more of the vulnerable population as we look at ways that's increasingly paid for by payers as they want to take the risk with us. But I also think looking at value for the entire population, including the people of Austin, which frankly 50% of are under age 35. And so looking at wellness going forward is what are some of the initiatives that we can be implementing to keep this next generation healthy while we also take care of the generation that today is in the midst of its obesity epidemic and has so many problems that we're catching up to. And so helping us look at that across all of those populations would be helpful.
Bill, the last comments of the night
I'm
belong
going
to
to answer
you.
the question by turning it around, is that the way you can help us is that we don't have a monopoly on ideas. but we are going to have a laboratory for testing them. As you may know, we're having some very small practices that we're launching, mostly as crucibles for studying new ways of doing things. And we've got a bunch of creative people there helping come up with the new ways, but we all, most or all of us come from academic backgrounds. We practice in usually inner city hospitals or tertiary quaternary referral centers, et cetera. We don't practice where you all practice, and so you may have ideas. I heard some of the things that you all have been talking about today about the way that you've been responding to the rapidly changing environment are creative, and some things I hadn't heard before. I mean, I love Randall's approach to, we're care providers, and the patients are healthier even before we operate on them. I don't know that anybody would have said that 5 years ago. So if there are ideas that you all have that you'd like us to test, again, we don't have a monopoly on them. We want to hear them, and then we have an opportunity for having a testing environment and see whether or not we could obtain the return on investment that we all want to make.
All right. Well, I want to thank all of our panelists and all of our audience for attending tonight. Please, thank you.